Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox, built for residents and fellows from PGY 1 to 5. This presentation was prepared by Dr. Bandar Ba, and the topic is about organophosphates and carbamates. By the end of this 10 minutes, learners should be able to recognize the cholinergic toxidrome, discuss the pathophysiology of cholinergic toxicity, and discuss the initial management for organophosphate exposure. Starting with a case, we have a 54-year-old male farmer who presents to the emergency department with severe shortness of breath and altered mental status. On initial examination, he's found to have a depressed level of consciousness, and his vital signs are as follows: heart rate 132, blood pressure 128/70, respiratory rate 32, temperature 36.3 degrees Celsius, and oxygen saturation 92% on room air. On further questioning of the EMS crew who was on scene, they revealed that the patient had a history of nausea, vomiting, and diarrhea prior to presentation. They also tell you that his house smelled like garlic, and that his wife said that some sort of chemical had spilled on him earlier in the day. Upon completion of the physical examination, you find that he has pinpoint pupils, wet skin, a wheezy chest, and ongoing passage of liquid stool. After your history and focused physical examination, putting all of this information you collected together, we have a chemical exposure in a farm that smells of garlic, wet skin, wheezy chest, altered mental status, vomiting, and diarrhea. The differential diagnosis is quite short and essentially contains only organophosphate toxicity. The cholinergic toxidrome can be recalled using the mnemonics dumbbells or sludges. The muscarinic cholinergic picture is essentially diarrhea, diaphoresis, urination, meiosis or mydriasis, bronchospasm and bronchorrhea, bradycardia, emesis, lacrimation, and salivation. There are two main chemical groups that give this cholinergic toxidrome, and these are the organophosphates, which comprise most of the pesticides, and carbamates, which are used as insecticides as well as medicinal agents. Organophosphates and carbamates are acetylcholinesterase inhibitors, meaning that their presence inhibits the degradation of acetylcholine at the synaptic cleft. This causes prolonged stimulation of acetylcholine receptors. To understand how cholinergic toxicity presents, we need to recall the structure of our nervous system and its receptor types. Nicotinic acetylcholine receptors are found in both sympathetic and parasympathetic preganglionic sites, which explains why we have some sympathetic and some parasympathetic responses. Nicotinic receptors are also found in skeletal muscle, which leads to muscle fasciculations. Muscarinic acetylcholine receptors are found only in parasympathetic postganglionic sites, which explains most of the cholinergic toxidrome we see with organophosphates and carbamates. One of the most important factors in treating the cholinergic toxic patient is to make sure that you, your staff, and other patients are all safe and not at risk of contamination by the affected patient. Therefore, decontamination should be considered and undertaken prior to any other measures. This can include activated charcoal for GI exposure, or exposing the patient completely and washing the body with soap and water for skin contamination. All of this must happen while keeping appropriate personal protective equipment in effect. With regards to management, the patient should receive ongoing standard supportive treatment for airway protection, hypotension, hypoventilation, etc. The antidote is atropine, which is a competitive inhibitor of acetylcholine at muscarinic receptor sites. Atropine is a life-saving drug in cholinergic toxicity, and a large amount of atropine may be required to save the life of a patient with cholinergic toxicity. Therefore, it's advisable to use the concentrated form of atropine when larger doses are required. The dose of atropine should be doubled every 5 minutes, until the chest is clear of secretions and there is good ventilation. It should be noted that atropine reverses the peripheral muscarinic effects of cholinergics only. The next strategy in management is the use of an oxime, such as pralidoxime. It prevents aging, or the permanent attachment of organophosphate to acetylcholinesterase, therefore regenerating the enzyme's activity. Pralidoxime can also bind unbound organophosphate and prevent their binding to nerve terminals. Pralidoxime is useful with organophosphates and not carbamates. Review questions. 1. Why does pralidoxime have limited use in carbamate exposures? 2. What's the laboratory test that can confirm organophosphate toxicity?